Hi, today we are going to learn about vascular distensibility and functions of the arterial and venous systems. You can read about this subject in detail in Guyton and Hall textbook of medical physiology. After listening to this lecture, you are going to be able to describe what vascular distensibility is, what vascular compliance is, and notice the difference between them. You will be able to tell the effect of sympathetic stimulation on vascular capacitance. You will be able to apply the concepts of stress relaxation and also reverse stress relaxation working in smooth muscles on the blood vessel walls. You will be able to describe the arterial pressure pulsation and explain why it damps in smaller vessels. You will be able to calculate pulse pressure using systolic and diastolic blood pressures. You will be able to list abnormal pressure pulse contours such as aortic valve stenosis, patent ductus arteriosus, and aortic regurgitation. You will be able to describe how to measure blood pressure indirectly by auscultatory method. Explain why Korotkov sounds are heard during blood pressure measurement and how to use them to determine systolic and diastolic blood pressures. And you will be able to calculate the mean arterial pressure. You will be able to describe the functions of the veins, define the relationship between peripheral venous pressure and right atrial pressure, tell what happens to the peripheral venous pressure when large veins are obstructed, define how the gravitational pressure can affect venous pressure in the feet. You will be able to describe how venous valves direct the blood flow towards heart in lower extremities and what venous pump is and how it works. And finally, you will be able to list the venous blood reservoirs in the body such as spleen, liver, abdominal veins, and skin. First, vascular distensibility. The distensibility of arteries allows them to accommodate the pulsatile output of the heart and average out pressure pulsations, which provides smooth, continuous blood flow through the small blood vessels of the tissues, capillaries. Veins are even more distensible than the arteries, allowing them to store large quantities of blood that can be called into use when it is needed. On average, veins are about 8 times as distensible as arteries in the systemic circulation. In the pulmonary circulation, the distensibility of veins is similar to that of veins in the systemic circulation. The lungs arteries, however, are more distensible than those of the systemic circulation. Vascular distensibility is normally expressed as increase in volume divided by increase in pressure times original volume. Vascular compliance or capacitance is the total quantity of blood that can be stored in a given part of the circulation for each millimeter of mercury of pressure. It is calculated as follows: increase in volume per increase in pressure. So this is equal to vascular compliance. Vascular compliance and distensibility correlates well. The greater the compliance of the vessel, the more easily it can be distended by pressure. Compliance is related to distensibility as follows. So compliance equals to distensibility times volume. The compliance of a vein in the systemic circulation is about 24 times as great as its corresponding artery, because it is about 8 times as distensible and has a volume that is 3 times as great. So altogether 24 times. In this figure, on the left hand side you see the aorta, on the right hand side you see the vena cava graphs. On the x-axis we see the transmural pressure, on the y-axis we see the relative volume change. So if you look at on the left hand side to the aortic curve, you see that the volume of the aorta increases positively when the pressure on the wall increases. There is a positive correlation, okay? On the other hand, if you look at the vena cava graph on the right hand side, in the very beginning you see that the vena cava is not round shaped, okay, it's flaccid, as you see. When the pressure increases, very low blood pressures actually, so around maybe 5-10 millimeter mercury or so, first its shape becomes ellipsoid, and then when you continue to increase the pressure in the wall of the vein, inside of the vein, you see the volume and shape increases. So great increase in the volume can be followed in the vena cava, and then it becomes round shaped. After some point it is no longer distensible, okay? So at low transmural pressures, apparent compliance is extremely high as the vein becomes fully rounded. At unphysiologically high, very high transmural pressures, the compliance will be very low. Why it is unphysiological? Because the pressure inside of the body can never reach this high, 52 or 100 millimeter mercury in the veins, okay? We see these pressures easily in arteries, in aorta, during systolic phase of the cardiac cycle. So if we are going to see what happens again in these graphs from Boron, another textbook of medical physiology. So the differences in compliance cause arteries to act as resistors and veins to act as capacitors. As we increase transmural pressure, arteries increase in volume. As they accommodate the volume of blood ejected with every heartbeat, large muscular systemic arteries, for example femoral artery, increase in radius by about 10%. This change for a typical muscular artery is much smaller than the distension that one would observe for elastic arteries, for example aorta, which have fewer layers of smooth muscle and are not under nervous control. The higher compliance of elastic arteries is evident in the pressure-volume diagram in figure 19.8a, obtained after the smooth muscle is relaxed. Veins, on the other hand, behave very differently. The pressure-volume diagram of a vein in the figure showed that compliance is extremely high, far higher than for elastic artery, and at least in the low pressure range. For a relaxed vein, a relatively small increase of transmural pressure from 0 to 10 millimeter mercury increases the volume by 200%. So, this high compliance in the low pressure range is not due to a property of elastic fibers. Rather, it reflects a change in geometry. At pressures below 6 to 9 millimeter mercury, the vein's cross-section is ellipsoidal. A small rise in pressure causes the vein to become circular without an increase in perimeter, but with a greatly increased cross-sectional area. Thus, in their normal pressure range, veins can accept relatively large volumes of blood with little buildup of pressure. Because they act as volume reservoirs, veins are sometimes referred to as capacitance vessels. The true distensibility for compliance of the venous wall related to the increase in perimeter produced by pressures above 10 mm mercury is rather poor, as shown by the flat slope at higher pressures in figure 19.8b. Okay, let's go back to the figure. I will come back to the next slide. Okay, now you see this explanation here. In the very beginning, the shape of the vein changes, increasing the cross-sectional area. So not only the pressure increases, so the volume increases, but also the shape of the vein increases. So in the very low pressures, the volume increase in veins is extremely high compared with aorta here. It is rather low compared with vein. In aorta, you need much higher increase in pressure to get an increase. For example, 150 to 300, you need to double the pressure from 50 to 100 millimeter mercury, whereas in the vein, if you go from 5 to 10, as you see, the volume increases quite much in the veins. Now, let's see the effects of sympathetic stimulation on the vascular capacitance. Sympathetic stimulation increases smooth muscle tone in the veins and arteries, causing a shift of blood to the heart, which is an important method used by the body to increase heart pumping. For example, during hemorrhage, enhanced sympathetic tone of the vessels, especially of the veins, reduces vessel size, so the circulation can continue to operate almost normally even when as much as 25% of the total blood volume has been lost. So in this figure, this is the artery and this is the vein. As you see, by sympathetic stimulation, it can increase the tonus, so the volume in the blood will be decreased a little bit, but in arteries, this decrease is very small. On the other hand, if you look at the veins, sympathetic nervous stimulation decreases the volume of the vein quite much. Here you see the sympathetic inhibition point and sympathetic excitation point. So the difference between these two is quite much, about 1000 milliliters or 1 milliliter, 1 liter of blood. Okay? So this is very important, especially if the person has bleeding or hemorrhage. We also call it hemorrhage in medicine. Then the volume of blood goes down, and then blood pressure goes down. Thanks to the sympathetic nervous stimulation, arteries, veins, all blood vessels will be constricted, so to decrease the vascular volume, so that will not allow quite much decrease in blood pressure. Sympathetic stimulation also increases the cardiac contractibility, so that the blood pressure is tried to be kept constant, relatively constant, to prevent the development of a shock table. Okay. Vessels exposed to increased volume initially exhibit a large increase in pressure, but delayed stretch of the vessel wall allows the pressure to return to normal. The effect of delayed stretch is often referred to as delayed compliance or stress relaxation. Delayed compliance is a valuable mechanism by which the circulation can accommodate extra amounts of blood when necessary, such as after a transfusion that was too large. Delayed compliance in the reverse direction permits the circulation to read just itself over a period of minutes or hours to a diminished blood volume after serious hemorrhage. So in this figure, you see that when we infuse fluid, for example, when we transfuse blood, let's say 100 milliliter of blood to a person, then or to an animal, then the blood pressure goes up quickly, as you see. What happens then? Then the smooth muscles on the walls of the blood vessel starts to be relaxed. So uh, the arteries and the veins will adapt to the new volume uh, without increasing the pressure much. So this is called delayed compliance or stress relaxation. Okay, the blood vessels will be relaxed. Will in this way the volume of the blood vessels will be increased and the pressure will be decreased, as you see. Okay. Uh, just opposite is also okay, also valid. If we take away, let's say, 100 milliliter of blood from the blood circulation by bleeding or simply by taking blood from the person, then the pressure in the blood vessel will suddenly goes down, as you see. After some time, this time the smooth muscles around the blood vessels will be constricted. Okay, will decrease the volume of the vein or artery, so that the pressure inside of the blood vessel will start to rise despite the decrease in blood volume inside, so that this prevents the decrease in blood pressure to very low values. So this is called reverse stress relaxation mechanism. Reverse stress relaxation. Okay, this was stress relaxation and this is reverse stress relaxation. Arterial pressure pulsations. With each heartbeat, a new surge of blood fills the arteries. Were it not for the distensibility of the arterial system, blood flow through the tissues would occur only during cardiac systole, with no blood flow flowing during diastole. The combination of distensibility of the arteries and their resistance to flow reduces the pressure pulsations to almost none by the time the blood reaches the capillaries, allowing continuous rather than pulsatile flow through the tissues. So in this figure you see aorta. Okay, by each cardiac systole the elastic aorta will be enlarged. Okay, by increased blood and increased pressure inside. So due to elasticity, it will be enlarged in the volume. And during the diastolic phase, this blood will try to return back to the left ventricle. However, seminal valves will be closed and will not let the blood to return to the left ventricle back. So the aortic wall will try to return its original position. So this aortic pump will continue to push, to press the blood inside, so that in the periphery the blood will be pumped as if the blood is continuously pumped by the heart. So the blood will flow smoothly in the periphery instead of pulsatile style. Okay, so this is called Wind-Castle effect, and you can watch here a video regarding this situation. Let's see, let's watch it if we can do it. Let's watch it. Here, the water is flowing. This is a tube, as you see. When you pump from this side, it is pulsatile. Now, it is flowing in a pulsatile style. Now, let's see when it is replaced with a balloon here, this part. It will represent the aorta. Okay, now it is modified. Now there is a balloon here between the tip and the tube, and we will again send water by pumping. But in this case, you see the blood flows continuously at the tip. Why? Because by each pump, the balloon will be enlarged, and then when the pump stops pumping, the balloon will continue to pump the blood, so that the blood flow in the periphery will be continuous. Okay, so this is a very nice example. I found this in YouTube, and so that you can easily understand the function of the aorta. So the balloon represents the aorta. So the aorta behaves like another pump. Okay, all right. In the young adult, the pressure at the height of each pulse, the systolic pressure, is normally about 120 mm mercury. Pressure at its lowest point, the diastolic pressure, is about 80 mm mercury. The difference between these two pressures, about 40 mm mercury, is called the pulse pressure. The two most important factors that can increase pulse pressure are increased stroke volume, that is to say, the amount of blood pumped into the aorta by each heartbeat. So it is normally 70 milliliter. By training in athletes, it can increase to 100 or more milliliters. And the second, decreased arterial compliance. Decreased arterial compliance can result when the arteries harden uh, with aging. This is called arteriosclerosis. Now you see the pressure pulse contour in the ascending aorta. We can send a catheter to the aorta from the femoral artery and then measure the pressure there. As you see in the diastolic phase, and in the diastole, the pressure goes down to 80, and when heart contracts, then left ventricle contracts, and the pressure increases quite much in the aorta. Okay, the semilunar valves are opened and the blood is pumped, and then during the diastolic phase again, the pressure starts to decrease. Okay, but it doesn't go to zero. Why? Because the semilunar valves are closed here. The incisura, the reason of this incisura is the closure of the semilunar valves in the orifice, on the orifice of the aorta. Okay, so this is the pulse pressure. The difference between systolic and diastolic pressures: 120 minus 80 millimeter mercury, we get 40 millimeter mercury. Okay. Abnormal pulse pressure contours can be seen in different pathophysiological conditions. Let's see. Some examples are shown here. For example, this is normal aorta, and here there is arteriosclerosis in elderly people. As we have said earlier, aortic wall, aortic wall or arterial wall becomes atherosclerotic and hardened, so no more elastic when the heart pumps blood into the aorta, since it's not elastic, it cannot store the pressure. It can suddenly transmit the blood to the periphery, so the pressure suddenly increases quite much. So in elderly people, systolic pressure is higher than young adults. The reason is hardened aorta, or no more elastic aorta, not that elastic, like we can say. So pulse pressure increases in elderly people. If you take 160 to minus 80, you will get 80 millimeter mercury. So pulse pressure is doubled in this case. Now, just opposite on the right hand side, in this figure, you see the aortic stenosis. There are some diseases affecting aortic valves, for example, rheumatic cardiac fever, rheumatoid fever. In this disease, there are antibodies produced against streptococci, and these antibodies cross-react with the tissues in the aortic valves, semilunar valves, and this inflammation is healed, uh, repaired, or recovered. There will be some fibrosis left, so the aortic valves cannot easily be opened, so that will be they will stay closed a little bit. So during cardiac systole, the blood cannot easily be pumped into the aorta, so the pressure does not go very high. So pulse pressure goes down in patients with aortic stenosis. Just opposite of this is aortic regurgitation. There are some diseases, if I remember right, Marfan syndrome, for example, in this connective tissue disease, there will be an enlargement in the size of the aorta, and then in this case, semilunar valves are not able to close the orifice of the aorta, so when the heart pumps the blood, uh, during diastolic phase, normally it should be closed, but since the valves are not able to close the hole, then the blood returns to the heart. So during systole, the heart has to pump uh, both blood coming from the lungs, oxygenated blood coming from the lungs to the left ventricle, and also the blood returning back from the aorta. So the volume of blood pumped each time increases in patients with aortic regurgitation. So as you see, diastolic pressure is very close to almost 0 millimeter mercury in aortic regurgitation. So since the pulse pressure is very, very high, almost equal to systolic pressure, then these patients had moves like this during each systole. Okay, their head even moves like this, and you can follow the capillary line moving back and forth also in the fingers, okay, in their nails, in these aortic regurgitation patients. And there is another example here. It is called patent ductus arteriosus. We will deal with these diseases in another lecture, but if I say a few words about this disease, there is a ductus between pulmonary artery and aorta open in intrauterine life in the embryo. So the blood comes from the ductus arteriosus from the placenta via ductus arteriosus. Okay, it arrives to the right ventricle, and it will be pumped to the lungs in embryonic life. However, since the lungs are not opened, the resistance in the lung capillaries is very high. So the blood will continue, oxygenated blood coming from the mother's uh, placenta, oxygenated blood will go to the aorta directly via this ductus arteriosus and then will go throughout the body. Okay, when the baby uh, was born, what happens? The baby breathes, and then resistance in the lung circulation will be decreased quite much. So now, when the blood is pumped by the right ventricle to the lungs, it will go to the lungs because the resistance now is very low. So it will not go to the aorta via this ductus arteriosus, and this ductus arteriosus will be closed within a few days, and it happens. Sometimes it doesn't. Okay, it stays open. So this is called patent ductus arteriosus. So open ductus arteriosus. In this case, in these children or patients, since the blood pressure is high continuously in the aortic blood vessel. So blood flows continuously from aorta to the pulmonary artery during both systolic and diastolic phases of the cardiac cycle. So you will hear murmur on the chest continuously in both systole and diastole in these patients. Again, in this case, there will be more blood pumped to the lung circulation or respiratory system. Why? Because more blood comes to the pulmonary artery. Blood, oxygenated blood comes back to the pulmonary artery from aorta and also from the body, peripheral circulation from the vena cava inferior and superior. The blood arrives to the right ventricle. It will be pumped by pulmonary artery to be oxygenated in the lung circulation. But at the same time, more blood comes from the aorta also. So lung receives much higher volume of blood, so that left ventricle has to pump more blood each time. So this also increases the pulse pressure in these patients. Okay, so it is easy to treat. You can ligate this patent ductus arteriosus by a small operation, or before that you can give anti-inflammatory drugs such as indomethacin, etc. Then it also helps this ductus arteriosus to be closed. If it doesn't work, then operation may be necessary. So I explained these. I think you can read this slide by yourself later on. The pressure pulses are damped in the smaller vessels. The pressure pulsations in the aorta are progressively diminished by first resistance to blood movement in the vessels, and the second compliance of the vessels. The resistance damps the pulsations because a small amount of blood must flow forward to distend the next segment of the vessel. The greater the resistance, the more difficult it is for this forward flow to occur. The compliance damps the pulsation because the more compliant a vessel, the more blood is required to cause a rise in pressure. The degree of damping of arterial pulsations is directly proportional to the product of the resistance and compliance. You see here, when it goes to the smaller and smaller blood vessels, this pulse pressure amount goes down, okay? And it is almost smooth, blood flow is almost smooth in the capillaries when it arrives in the capillaries. So how to measure blood pressure? You can insert a catheter into an artery or vein and you can directly measure it, but it's an invasive method. So it is an invasive method. Instead, we use non-invasive, not harmful method to the patient. It's called indirect method, indirect auscultatory method. Okay. With the auscultatory method, a stethoscope is placed over a vessel such as antecubital artery, and the blood pressure cuff is inflated around the upper arm proximal to the blood vessel. As long as the cuff inflation is not sufficient to collapse the vessel, no sounds are heard with the stethoscope, despite the fact that uh, blood in the artery is pulsing. When the cuff pressure is sufficient to close the artery during part of the arterial pressure cycle, a sound is heard with each pulsation. These sounds are called Korotkov sounds. When determining blood pressure by auscultatory method, pressure in the cuff is first inflated well above the arterial systolic pressure. As long as the pressure is higher than the systolic pressure, the brachial artery remains collapsed and no blood jets into the lower artery during cardiac cycle. Therefore, no Korotkov sounds are heard in the lower artery. As soon as the pressure in the cuff falls below the systolic pressure, blood slips through the artery underneath the cuff during the peak systolic pressure, and one begins to hear tapping sounds in the antecubital artery in synchrony with the heartbeat. As soon as these sounds are heard, the pressure level indicated by the manometer connected to the cuff is about equal to the systolic pressure. Okay? So here you see this is the cuff, this is the stethoscope and the manometer. You inflate the cuff uh, over the estimated systolic pressure and then start to decrease the pressure in the cuff. When the pressure is very high, blood does not flow in this artery, so no sound can be heard. When the pressure inside the cuff is equal to the arterial pressure, then you start uh, blood flowing uh, in the highest point. So we can hear the sound, Korotkov sound. So the first sound heard shows us the systolic blood pressure. We continue to hear the sounds when we decrease the pressure inside the cuff, and then this sound will be lost when the pressure becomes lower than the diastolic pressure. Okay, so this point where the sound is no longer heard shows us the diastolic blood pressure. Okay. As pressure in the cuff is further lowered, the Korotkov sounds change in quality, having a rhythmical, harsher sound. Finally, when the pressure in the cuff falls to the level of the diastolic pressure, that is to say the artery no longer closes during diastole, the sounds suddenly change to a muffled quality and then usually disappear entirely after another 5 to 10 millimeter drop in cuff pressure. When the Korotkov sounds change to the muffled quality, the manometer pressure is about equal to the diastolic pressure, although this slightly overestimates the diastolic pressure. Many clinicians believe that the pressure at which the Korotkov sounds completely disappear should be used as the diastolic pressure, except in situations in which the variance of sounds cannot reliably be determined because sounds are audible even after complete deflation of the cuff. For example, in patients who have arteriovenous fistulas, for hemodialysis or aortic insufficiency, Korotkov sounds may be heard after complete deflation of the cuff also. How about mean arterial pressure? Mean arterial pressure can be estimated from the systolic and diastolic pressures measured by the auscultatory method as follows. Mean arterial pressure equals to 2/3 of the diastolic pressure plus 1/3 of the systolic pressure. Why is that? Because diastolic phase of the cardiac cycle lasts 2 times longer than the systolic phase of the cardiac cycle. So in an average young adult, Mean arterial pressure can be calculated as 93.3 millimeter mercury. In this figure, here in the young adult, it's this point. By the age, increase in age, you see the mean arterial pressure increases a little bit. Diastolic pressure also increases a little bit, but the systolic pressure increases quite much compared with mean or diastolic pressure. Well, why is that? Because of the atherosclerosis, okay? Because of the stiff, hardened arteries. By aging, the systolic pressure increases, so the aorta is no longer that much elastic in elderly people. So hypertension we see in elderly people much commonly. Now, second half, we can say arteries are over. Now the veins we are talking about. As discussed previously, the veins are capable of constricting and enlarging and thereby storing either small or large quantities of blood, making this blood available when it is needed by the circulatory system. Veins can also propel blood forward by means of a venous pump, which helps regulate cardiac output. Relationship to the right atrial pressure, central venous pressure, and peripheral venous pressure. Because blood from systemic veins flows into the right atrium, anything that affects the right atrial pressure usually affects the venous pressure everywhere in the body. Right atrial pressure is regulated by a balance between the ability of the heart to pump blood out of the right atrium and a tendency of blood to flow from the peripheral vessels back to the right atrium. Normal right atrial pressure is about 0 mm mercury, but it can rise to as high as 20 to 30 mm mercury under abnormal conditions, such as with serious heart failure or after a massive transfusion. So here you see the natural reference point of the right atrium. It is close to tricuspid valve. So it is the valve in the right side of the heart, right between right atrium and the right ventricle. Increased venous resistance can increase the peripheral venous pressure. When large veins are distended, they offer little resistance to blood flow. Many of the large veins entering the thorax are compressed by the surrounding tissues. However, so they are at least partially collapsed or collapsed to an ovoid state. For these reasons, large veins usually offer significant resistance to blood flow, and the pressure in the peripheral veins is usually 4 to 7 mm mercury higher than the right atrial pressure. Partial obstruction of a large vein markedly increases the peripheral venous pressure distal to the obstruction. So here, compression points that tend to collapse the veins entering the thorax are shown in this figure. Here there are ribs, here there is clavicula here. So atmospheric pressure collapsed in the neck, and the rib collapse here, as you can see, and abdominal pressure collapse here, and introthoracic pressure also affects the pressure around large veins due to respiration. You know, during respiration, intrapleural pressure becomes lower than the atmospheric pressure, and during inspiration, and higher than the atmospheric pressure during expiration. Increased right atrial pressure increases peripheral venous pressure. When the right atrial pressure rises above its normal level of 0 mm mercury, blood begins to back up in large veins and open them up. Pressures in the peripheral veins do not rise until the collapsed points between peripheral veins and the large central veins have opened, which usually occurs at a right atrial pressure of about 4 to 6 mm mercury. When the right atrial pressure rises further, as occurs during severe heart failure, it causes a corresponding rise in peripheral venous pressure. Gravitational pressure affects the venous pressure. Pressure at the surface of the body of water exposed to the air is equal to the atmospheric pressure, but the pressure rises 1 mm mercury for each 13.6 mm mercury distance below the surface. This pressure results from the weight of the water and therefore is called gravitational hydrostatic pressure. Gravitational hydrostatic pressure also occurs in the vascular system because of the weight of the blood in the vessels. In an adult who is standing absolutely still, pressure in the veins of the feet is approximately 90 mm mercury because of the hydrostatic weight of the blood in the veins between the heart and the feet. As you see in this figure, the effect of gravitational pressure on the venous pressures throughout the body in the standing person is shown. As you see in the head, in sagittal veins, the pressure is minus 10 mm mercury. Here we should be careful if we happen to open the skull, such as in neurosurgical operations. This negative pressure can suck the air inside. So neurosurgeons should be aware of that and should be careful about that. Can cause air embolism easily. Okay, what else we see here in the hand? As you see, the blood in the vein of the arm causes 35 mm mercury pressure in the hand, whereas it is 22 mm mercury in the abdominal vein, and it is 90 mm mercury in the dorsal side of the foot, in the veins of the dorsal side of the foot, so very high. How to take this blood back to the heart? Against gravity, it is not easy. The venous valves and the venous pump influence venous pressure. Were it not for the valves of the veins, the gravitational pressure effect would cause venous pressure in the feet to always be about plus 90 mm mercury in a standing adult. Each time one tightens the muscles and moves the legs, however, this compresses the veins either in the muscles or adjacent to them and squeezes the blood out of the veins. These valves in the veins are arranged so the direction of blood flow can only be toward the heart. Consequently, each time a person moves the legs or tenses the muscles, a certain amount of blood is propelled toward the heart, and the pressure in the veins is lowered. This pumping system is known as the venous pump or muscle pump, and it keeps the venous pressure in the feet of a walking adult near 25 mm mercury. So in this figure, you see the venous valves in the leg. These valves allows blood to flow only towards the heart, not backwards. And in this figure, you see the skeletal muscle pump around the veins. So when skeletal muscles contract, they move blood towards the heart. They have the blood to move towards the heart. So during muscle contraction, venous diameter decreases and the venous pressure increases. The increase in pressure forces the flow only toward the heart because backward pressure forces the valves in the veins to be closed. Okay? The valves will not let the blood to go downwards. Blood flows only towards the heart. If a person stands perfectly still, however, the venous pump does not work and venous pressure quickly rises to the full hydrostatic value of 90 millimeter mercury. If valves of the venous system become incompetent or are destroyed, the effectiveness of the venous pump is also decreased. When the valve incompetence develops, greater pressure in the veins of the legs may further increase the size of the veins and finally destroy the function of the valves entirely. When the function of the valves is destroyed entirely, varicose veins develop and the venous and capillary pressures increase to high levels, causing leakage of fluid from capillaries and edema in the legs when standing. So, especially teachers, nurses, housewives, we see varicose veins in the legs because they stay in standing position without moving for a long time. So it is not good to stand to stay in standing position for a very long time. So you can see this news in soldiers, guards standing very long time in hot environment can cause fainting. Okay. The veins function as blood reservoirs. More than 60% of blood in the circulatory system is usually contained in the veins. For this reason, and because the veins are so compliant, the venous system can serve as a blood reservoir for the circulation. For example, when blood is lost from the body, activation of the sympathetic nervous system causes the veins to constrict, which takes up much of the slack of the circulatory system caused by the lost blood. Certain portions of the circulatory system are so compliant that they are especially important as blood reservoirs. These areas include first spleen. Spleen can sometimes decrease in size to release as much as 100 milliliters of blood into the reservoir of the circulation. What is interesting is that the blood received from the spleen contains a much higher amount of erythrocytes. The hematocrit percentage of the blood coming from the spleen is quite high, so it provides extra volume of blood to the blood circulation and also extra erythrocytes to the blood circulation, so that helping to transfer more oxygen from the lungs to the tissues. So you can see the structure of the spleen here, the red pulp you can see here. So all erythrocytes are removed from the blood circulation by spleen. The second organ providing extra blood is the liver. The sinuses of which can release several hundred milliliters of blood into the remainder of the circulation, and the other one is the large abdominal veins, which can contribute as much as 300 milliliters of blood, and finally venous plexus under the skin, which can continue several hundred milliliters when it is needed. So today we learned about arteries and veins and their functions. Thank you very much for listening.